we'll be seeing one more ABG. So in this acid arterial blood gas analysis, what we can say is the pH is 7.3. It means this is acidemia. So the ABG shows acidemia because the pH is less than 7.35. And the second thing that we need to say is we need to say this PCO2 versus this bicarbonate. So last time also I had told that bicarbonate normal range is between 22 to 26 and PCO2 normal range is between 35 to 45. So to have an acidemia, bicarbonate need to be less than 22 and PCO2 need to be more than 45. This is either of them or they both can be present at the same time. This can happen in uncommon cases. So in this case, the bicarbonate is 27.7. It means it is not less. In fact, it is more. But the PCO2 is definitely high. So in short, this fits. So PCO2 is higher. It means that this is more of a primary respiratory acidemia. So in this case, PCO2 is high, that is more than 45, and this is the reason for acidemia. That is the reason what our diagnosis is. It is basically primary respiratory acidemia. So PCO2 is high. What is the meaning of this? It means the patient is having significant carbon dioxide retention. It means the patient is not able to wash out the carbon dioxide. Now, why would this happen? This could be because of some reasons. For, for example, if patient's RR is very less, if patient is not breathing out, this could be the reason. RR is very less if patient is apneic or if patient's respiratory rate is suppose like 8 or 4 or 6, then patient will not simply wash out the carbon dioxide. This usually happens, but in uncommon situation. The second thing is if patient has wheeze, patient has rhonchi, or patient has acute bronchoconstriction. In that condition, what exactly happens is this patient's bronchi, bronchioles, which actually is the respiratory tract, they usually get blocked. They usually get clogged because of the mucus secretions. So when they are breathing in, these bronchioles they open up. They open up basically because the patient is applying positive pressure. But whenever patient is breathing out, these bronchi or bronchioles basically gets blocked because of the pressure. So whatever CO2 is flowing out won't get out. This happens. So that is the reason why there is retention of the CO2. What are the other reasons? There are so many other reasons as well. For example, in poisoning, in sedative poisoning like alprazolam poisoning, etizolam poisoning, uh, in OPP poisoning as well, there is bronchoconstriction as well as respiratory depression. So there is significant respiratory depression. So patient won't take breaths and CO2 is not washed out. This simply causes CO2 to build and build and more and CO2 then increase. So this PCO2 basically increases. So increase in the levels of CO2 then combines with water to form this H2CO3, and this H2CO3 then dissociates into H plus and HCO3, and this H plus is all acid and this results in acidemia. This is very simple. So to counteract this, body has to definitely produce more of a alkali. So the reverse of acid is alkali. So to tackle this acidemia, alkalemia has to be produced, or alkalemia has to be done so that the pH can be balanced. Because acidemia, last time also I told, one of the most important thing that we always need to remember about acidemia is acidemia, it reduces the inotropic activity. It reduces the inotropic activity of heart, so that heart won't pump, and it is very difficult for the heart to maintain the blood pressure. The second thing that very commonly is associated with acidemia is hypotension, and this hypotension can be really very resistant to the treatment. It means कि it could be definitely difficult to treat this hypotension, and the inotropic supports, may it be NORAD, may it be vasopressin, may it be dopamine or dopamine, they won't respond to lower dose. Usually, the dosage required to maintain the blood pressure, to maintain the systolic blood pressure of at least 100 millimeters of mercury, becomes very difficult. So, patient may be needing the NORAD support of 20, 30 ml per hour, vasopressin of 1 to 2 ml per hour. That may be required in such circumstances. So, acidemia has to be treated very carefully. And the third important bad thing about acidemia is, in acidemia, the risk of arrhythmia is significantly high, is very high. So, arrhythmia in acidemia is significantly high because acidemia is very commonly associated with hypotension and very commonly associated with electrolyte imbalance. And in electrolyte imbalance, one of the most important thing is potassium. Very commonly, if potassium is more than 6 milli equivalent per liter, or if it is less than 3.5, then the chances of arrhythmia are through the roof. The chances of ventricular tachycardia, ventricular fibrillation, cardiac asystole, they are extremely high if acidemia is present with hypotension and electrolyte imbalance, especially hyperkalemia or hypokalemia. So, and in this case, we can very clearly make out that the potassium is high. So we definitely have to confirm this through the electrolyte that is sent separately as well. But the pH is lesser, the potassium is very high, and this is a very deadly combination. Now, what other things we have to say is, we need to remember one thing, that whenever there is excess of PCO2, so whenever PCO2 rises, so that it will cause respiratory acidemia. So we can directly come to know whether this is an acute respiratory acidemia or whether it is a chronic respiratory acidemia. Acute means this can happen in poisoning. This can happen in acute bronchitis. This can happen in cases where there is sudden acute respiratory depression, like traumatic brain injury, like intracranial bleed or huge stroke that is causing brainstem herniation, or that is causing brainstem suppression, and that can cause this respiratory depression. This is in acute setting, and in chronic setting means those patients who are known case of asthma, known case of COPD, known case of restrictive lung disease, those patients who have so many episodes of repeated hospitalizations. So those patients are more of a chronic patients with chronic respiratory acidemia. So we can come to know whether patient has this acute or chronic respiratory acidemia. So in what happens actually in acute respiratory acidemia, per 10 uh, millimeters of rise of PCO2, you have 1 millimole rise of bicarb. So what we can see is it is around 65. The normal range of PCO2 is from 35 to 45. So on an average, we'll take it as 40. So it means ki it is increased by 25, right? So it was supposed to be around 40, but now it has become 65. So it is increased by 25. So per 10, you have 1 millimole of bicarb increased. So in short, for 25, the rate should be 2.5 millimoles. So on an average, bicarbonate level is between 22 to 26. So on an average, bicarb is around 24. So 24 should go up to 27, and in this case it is around 27 because there is a standardized bicarb. So this perfectly fits in acute respiratory acidemia. If it would have been chronic respiratory acidemia, in that scenario, for per 10 millimeters of PCO2 rise, what you get is around 3.5 millimoles of bicarbonate rise. So, in this scenario, for 25, it should have been around 8.5 millimoles of bicarbonate rise. So it could have been up to 32. So you are not simply seeing this bicarbonate, you have to see the standardized bicarbonate. So this is more of a corrected bicarbonate levels that you have to see. So this is a very nice case of acute respiratory acidemia with hyperkalemia, which puts the patient at a very, very high risk of arrhythmia and which has to be treated very aggressively via mostly NIV if patient is conscious, obeying, and if it is feasible. And if it is not feasible, if patient's sensorium is not good, then intubation. And after intubation, the selective setting of NIV, selective setting of ventilator has to be made to wash out this PCO2. Thank you.